Hello. Hello, my name is Gemmy. I'm from the Singapore National Eye Centre. It is my great pleasure to join this meeting today, and I'm going to talk about how has my practice changed with OCT angiography and foreign retina workplace. These are my disclosures, and I receive honorarium from ZEISS for this presentation. One of the key advantages from OCT angiography is the ability to assess the retina depth resolved layer by layer. And on the angioplex, there are 10 very useful preset slabs that I use on a daily basis, and I will go through with you some examples of which slabs I will use particularly for which diseases. So to start off with retinal vasculature, I will start off with using the vitreoretinal interface, superficial and deep plexus, and the corresponding segmentation lines can be seen here to generate this on-fast image. So for an eye that doesn't have a distorted anatomy, the presets work very well, but if there are areas of swelling or extreme thinning, it is important to check that these segmentation lines are where you want to be, and if necessary, we can adjust them to make sure that we generate a nice image. Moving on to choroidal neovascularization, I would generally screen with the avascular or as well as choriocapillary slabs. As you can see, the segmentation lines shown here. ORC, by the way, stands for outer retina choriocapillaris. If I see a suspicious CNV lesion, I would then further refine it by using the RPE fit and sub-RPE slabs. Now, these two slabs are particularly useful and different, as you can see that most of the other slabs consist of two pretty much parallel lines like that, whereas in eyes with a PED, it is important to follow the RPE contour, and here's what the RPE fit is doing, following the RPE as the upper boundary and the Brooks membrane as the lower boundary, whereas with the sub-RPE slab, it is two lines are parallel to the RPE fit, which is particularly useful to look for type 1 neovascularization that is a thin layer just below the RPE. So let's start off looking at some retina vasculature abnormalities, particularly applicable to eyes with diabetic retinopathy as well as vein occlusion. So in terms of clinical management, my decision on the day by looking at this OCTA without using an FA general is to answer whether I need to perform panretinal photocoagulation. The other area we look at is the macula, mainly to look for macular ischemia. Here is not so much a injection decision, because with injection, I still generally use the structural OCT to look at swelling. However, if I see macular ischemia, it helps me counsel the patient in a different manner. I would counsel them about the length of the course of injection, the likelihood of recurrence, as well as the visual prognosis that could be achieved. So when we look at the retina, we can start off with a 3x3 area. It's a small field, but it affords the highest resolution in terms of details. But often we want to look at a larger area, so we can also use a 6x6 as well as an 8x8, which are preset protocols, very easy to use on this instrument. If we want to look further, or for presentation purpose, sometimes we can generate a montage with 14x10 or 14x14. These are really good images to survey the posterior core. Look at some examples now. Here is an eye with a sclerosed vessel along the intratemporal arcade with no edema. On the FFA, we can appreciate a large area of non-perfusion and some leakage from neovascularization. How does the OCTA look, and can I get the same information? Indeed, I can. This is using the superficial slab. We can immediately appreciate the large area of non-perfusion, and just purely by that, I would be making the decision to perform a sector PRP. You say, well, where are the neovascularizations? We could see them so clearly on the FA. Here is how we look for neovascularization on the OCT angiography. Remember that there is no leakage on OCT angiography. However, if we use the other property of neovascularization, that they are pre-retinal, they breach the internal limiting membrane, and therefore just purely by placing them in the vitreoretinal interface lab, as you can see on the left-hand side, these are the segmentation lines. These are clearly in front of the retina. So these two fronts of vessels are neovascularization. So the whole picture is in keeping with the same information that I could get from the FFA. So generally in diabetics and RVO patients, I have been performing much less FFA lately. Just to show you another example, again, we can appreciate the sclerosed vasculature along the infratemporal arcade. On the superficial plexus, we can appreciate the non-perfusion, and here is the front of vessel, and we assign a color code. The red front is what is detected in the vitreoretinal interface, and that is a front of fibrous neovascularization with the background area of large area of non-perfusion. This is an eye that requires sector PRP. And another example, an eye that has already undergone sector PRP, but clinically we suspect there is still an area of neovascularization, and indeed on the superficial plexus, nothing surprising. We can outline the extent of the non-perfusion, but again, using the VRI, we can appreciate two fronts of neovascularization, which fit with the leakage area that we can see on FA. Again, just demonstrating that OCTA really gives you all the information you can get without needing an FFA now. Going to the macular area now. So traditionally on FA, we can appreciate enlargement and irregularity of the outline of the foveal avascular zone. But because of the invasive nature of the FA, we generally don't perform it unless the vision is poor. However, now with OCT angiography, we can appreciate some degree of FAC abnormality is actually very important in many patients, even though their vision is relatively normal. So clinically, we would call this eye quite a successful, stable post-PRP eye. But look at the OCT angiography. Despite the relatively good vision of 6/12, FAC is enlarged as well as irregular. Not only that, we can also appreciate the changes are often even more marked in the deep plexus, which is not well visualized in the FFA. Now we can appreciate these changes qualitatively, but also measure them and get a number, so we can longitudinally assess for any progression. So we can assess the amount of vasculature and perfusion on the area scanned using these angioplex metrics with the vessel density or perfusion density. For the FAC itself, we can automatically outline it using the angioplex metrics, and we can quantify the FAC area as well as circularity. So this is just to show you the screen, the standardized screen. On the left-hand side are the range of preset slabs that you can see. And here we have selected the superficial plexus in the middle. And on the bottom right is exactly where we can use the angioplex metrics. And just to enlarge that, you can see we have selected vessel density, and it can show it according to the area of the ETDRS grid, as you can see here, an example, as well as below is the FAC in terms of area, perimeter, as well as circularity. Now with these numbers, we can then follow these eyes longitudinally to assess for any changes, whether it's improvement or deterioration. So as shown here, we have two visits of that same eye side by side. We can assess the image both of the OCT angiography as well as a structural image in terms of the swelling, as well as the angioplex metrics down at the bottom. So these are very useful clinical tools, and we have published a couple of papers demonstrating that despite very relatively good vision, we find that with increasing severity of diabetes, there is deterioration in terms of the FAC size, and also, although visual acuity may be quite good, there is a functional deficit which we can measure on microperimetry. And over time, some of these abnormalities can predict loss of vision when we look at longitudinal progression as well. So we then now move on to the second part of this talk, which we will talk more about the choroidal neovascularization, outer retina now. So as mentioned, I would screen for any neovascularization using the avascular retina or outer retina to choriocapillaris as well as choriocapillaris slab. And here we don't see anything abnormal. and there is no CNV. And then I will then refine if on the ORCAS, you can see on the left-hand side that there is clearly a network there. I would use the RPE fit and sub-RPE slabs to refine where is this in terms of above or below the RPE. So in clearly neovascular cases, that's obviously useful, but in fact, I find it even more useful in the less, in the more subtle cases. And two important entities to look out for are the so-called pachychoroid eyes, where there is a little bit of fluid. We're not sure if it is just central serous or it is actually complicated by a secondary CNV. So in the top example, we now learn that especially if there is a shallow irregular elevation of the RPE, often on the OCTA, we can appreciate that it's harboring a very small type 1 neovascularization already. Of course, the choroid is thick. There is likely also a central serous background to this eye. In the bottom example, this kind of eye, there is no fluid. In the past, we thought it was all drusen or drusenoid PED, but now with OCT angiography, we appreciate that many of these eyes actually have neovascularization, although it is still in the non-exudative stage. It doesn't require treatment, but if we follow these eyes up, the chances of it starting to leak is much higher. So, as I mentioned, if you already suspect an eye has neovascularization, often in my practice, I would still continue to do an FA-ICG at baseline to document the lesion. The difficulty is that once we've started treatment and the eye has dried up, vision has improved, then one feels a bit reluctant to repeat the FA-ICG, but still I want to know whether there is still neovascularization and particularly whether there is still polypoidal lesion. So this is where after an initial course of treatment, for example, 3 injections with or without laser, you can appreciate on the structural OCT there is not much fluid, but there is a PED, and I want to know if there is still polypoidal lesion. And here using, first of all, the ORCS lab on the left-hand side, and on the right-hand side, the RPE fit, I can appreciate that at the bottom here, there is likely still a polypoidal complex. And we've published that if you kind of find a flow signal in this kind of configuration with a focal flow signal inside the RPE, often with a sharp peaked PED with a ring sign in the middle, that is highly suggestive of a residual polypoidal lesion. Whereas if you have a very shallow layer of flow signal, like the one that I showed you, like a type 1 with the RPE fit and sub-RPE, that is usually just a type 1 neovascularization. Here is another example showing you a post-treatment eye. On the left-hand side is the baseline presentation, clear polypoidal complex. We applied combination therapy. On the right, using the RPE fit slab, we can demonstrate persistence of this complex after 3 injections, after the combination therapy. I want to show you this other case is really interesting. So this is an eye that has geographic atrophy that we've been following up for several years, and this year, earlier on, she suddenly developed neovascularization. As you can see, there is intraretinal cyst and there is an elevation of the RPE. When we did the FA and ICG, as you can see on the left-hand side, the FA showed a lot of hyperfluorescence in the area of geographic atrophy, and it becomes hard to tell whether that is CNV or purely window defect from the geographic atrophy. And in fact, on the ICG, it's dark over that area, suggestive it is really just geographic atrophy. And the neovascularization is mainly a type 1 that is surrounding the rest of the area, wider area. That is all guesswork, but the OCTA confirmed that very clearly. In the area of geographic atrophy, there is no neovascularization. And here clearly you can see a type 1 neovascularization surrounding this area of geographic atrophy. Again, showing you different slabs here in the avascular slab, as well as in the deeper RPE fit, clearly showing that this neovascularization is below the RPE. It is a type 1 lesion. What is interesting to look out for is here now I show you the choroid slab at the top, and what appears to be bright here is really due to unmasking of the underlying choroid with choroidal vessels within that area of geographic atrophy. So I think this case really demonstrates how the OCTA is very useful for us to refine where the vasculature is, whether it's above the RPE, between RPE and Brooks membrane, and below it inside the choroid. So a final couple of minutes just to discuss the Zeiss forum. So we've discussed the OCTA in isolation, but now it is important to combine different modalities. So multimodality imaging is important, and Zeiss forum is one single platform that allows us to combine and overlap the different modalities of images. It can also allow us to track longitudinal changes, as you can see here in the Retina workplace, and you can highlight when the injection was given and how the OCT and OCTA quantitative measurements are changing over time, and help us to evaluate and monitor progression of macular diseases during treatment and navigate 3 data sets simultaneously with OCT structural, OCT angiography, and you can also look at the color fundus images, as you can see with the Claris. So this is showing you the macular thickness on the OCT structural scan. And here, again, you can see the longitudinal changes, as well as using the OCT angiography. And finally, the color fundus, and you can overlap the different modalities and toggle them one from the other. So this is very useful, particularly if your workplace is like in SNEC, where we often work remotely, not at the machine, but for example, in my office, I want to access the various images. The forum is a very convenient workplace for us. So just to summarize, in my clinical practice, the OCTA doesn't just provide a beautiful picture, but is really clinically important, helps me cut down the need of FA, make clinical decisions about neovascularization and peripheral ischemia, and therefore the need for performing PRP. It allows me to assess macular ischemia and therefore counsel my patients undergoing anti-VEGF therapy much more detailed. It allows me to screen for the presence or absence of neovascularization, particularly useful in eyes that has a background of central serous, as well as those non-exudative eyes, especially in the fellow eyes of patients already presenting with unilateral active CNV. And finally, after initial course of treatment, it is useful to assess polypoidal closure or persistence of the network, even when the fluid has dried up. OCTA shows me the structural nature of the neovascularization as well. So with that, I will end my talk, and once again, thank you very much for the opportunity to share.